In short, in patients who have an atherosclerotic cardiovascular disease risk of less than 10%, you start treatment only once the pressure goes beyond 140 by 90. That is, you start drug treatment. Your aim in all conditions is to keep it less than 130 by 80. In patients who have had a heart disease or a stroke in the past or have an atherosclerotic cardiovascular disease risk more than 10% or have other conditions like chronic kidney disease, peripheral vascular disease, start treatment early at 130 by 80 or more, and immediately your target is to keep it less than 130 by 80. So now that we have looked at the targets for treating hypertension, we would want to look at a very interesting concept which is called secondary hypertension. So, what's secondary hypertension? Secondary hypertension is when you have hypertension due to some other condition. Okay, that blood pressure is not primary but secondary to some other disease. As you can see, the most common causes are kidney diseases, chronic kidney disease, sometimes renal vascular disease like renal artery stenosis can be a cause. One of the more up and coming causes of secondary hypertension, especially due to a lot of obesity, is obstructive sleep apnea, a condition which we will discuss in the future. Drug and alcohol induced conditions are also the cause of secondary hypertension. The less common secondary causes of hypertension include predominantly endocrinological causes like hyperaldosteronism, pheochromocytoma, Cushing syndrome, both hypo and hyperthyroidism, hyperparathyroidism, acromegaly, and aortic coarctation. So, knowing that there are certain secondary causes of hypertension, we need to know which patients might be coming with secondary causes. Why do we need to know that? Because if you pick out which are the causes of secondary hypertension, you don't need to really give the patients antihypertensives. You need to treat the underlying cause. For example, treat the Cushing's, it disappears. If it is primary hyperparathyroidism due to a tumor, remove the tumor. You do not spend so much time and effort treating the hypertension alone. It could be renal artery stenosis, dilate the renal artery. So there the treatment is treat the primary condition. Okay, you might be able to do a reversal of the hypertension in these patients. Very important thing, patients with secondary hypertension might look very much like a patient with primary hypertension. The question is, when do you suspect secondary hypertension? Okay, so here is a list of conditions that you need to always suspect secondary hypertension. So here is a patient who, if the patient comes to you with new onset or uncontrolled hypertension, especially if it is resistant to drugs, okay, we will discuss what is resistant hypertension subsequently. If the hypertension happens suddenly, the patient presents to you in a hypertensive crisis, okay, or if the hypertension occurs at less than 30 years of age, if the patient was previously well controlled and there is a sudden increase in his blood pressure. If the patient has come to you with minimal amounts of hypertension, but the patient is having severe organ damage like kidney damage or eye damage, which we will discuss. If the patient has come to you with a hypertensive emergency, older terms for that is accelerated or malignant hypertension, we will touch on that next. If the patient is showing diastolic hypertension, okay, usually it is systolic hypertension that you see in people beyond 65 years. But if you see diastolic hypertension, again, you should think, okay, if the first hypertension turns out to be diastolic, that also gives you a hint that the patient might be having a secondary hypertension. If the patient is having hypokalemia, okay, usually that hypokalemia is a sign of mineralocorticoid excess. You will have hypernatremia, hypokalemia, hypertension. In conditions like excessive mineralocorticoids, that is in Cushing's or in Conn syndrome, you might see that. So when you have such a patient, or the patient is very obese, gives you history suggestive of obstructive sleep apnea, is obviously having some endocrinological pathology. That's when you should think, am I dealing with a secondary hypertension? The point in secondary hypertension is to identify patients who might have secondary hypertension and treat the underlying cause. Do not waste your time and effort by increasing hypertension, antihypertensive drugs when you can always treat the cause and get a better result. Now we move on to another condition which is called resistant hypertension. Okay, we define resistant hypertension as blood pressure of more than 130 by 80, that is uncontrolled blood pressure on three antihypertensive medications. Okay, more than three or more antihypertensive medications, and still you're not able to control the blood pressure. And these antihypertensive medications should include a powerful diuretic, right? So resistant hypertension is where you're not able to control the blood pressure even after giving three drugs including a diuretic. It can also be called resistant hypertension if you are able to control the blood pressure but require more than four antihypertensive medications. That is, four or more. Okay, to be more accurate, four or more antihypertensive drugs are required to keep the blood pressure low. This is what is called resistant hypertension. Now, when you say resistant hypertension, the first step is see why the patient has resistant hypertension. One of the reasons is probably the patient is not complying with the treatment, or other is that he's still continuing to have some behavior or some risk factor that is increasing the blood pressure. This can be that the patient has untreated obstructive sleep apnea, or maybe the patient has some psychological problems because of which she is sleep deprived, right? Or maybe the patient is taking alcohol or some other illicit drugs which raise the blood pressure. So these are things that you need to ask the patient before you say this is resistant hypertension. I cannot offer any treatment to you. First, rule out those reversible causes. Once you have ruled out the reversible causes, there you have to look at the other methods that we have to manage resistant hypertension. We increase the diuretic to maximum dose first. Okay, we can add mineralocorticoid receptor antagonists, okay, like aldosterone antagonists. Okay, you have spironolactone, you have eplerenone. These work very well to reduce the blood pressure. If you have chronic kidney disease, loop diuretics like furosemide or torsemide might really work in some patients. In those patients who have already used a diuretic, try adding a calcium channel blocker, or you can add a ACE inhibitor ARB. This is also the time to try certain drugs which have a poorer side effect profile. Many people try to use drugs like clonidine or prazosin, which can produce a lot of first dose hypotension during this period. So it's in resistant hypertension management that we introduce such drugs like clonidine or prazosin to try and control even after giving 2 to 3 drugs. There are, however, a few newer modalities of management. In our show notes, you will see a greater description of these techniques, but I'll just tell you briefly. In patients who have uncontrolled blood pressure, you can do two things. One of that is called baroreceptor activation therapy. This is where you have electrodes implanted in the carotid baroreceptor, and regular pulses from a electrical device will basically activate your baroreceptors. You know that normally the baroreceptors are activated by high pressure. Here, the electrical stimulus activates the carotid baroreceptor. It tells the brain, it tells the vagus to slow down the heart and also produce vasodilation, reducing the blood pressure. So there are studies that have now tried this and have shown that there is good amount of reduction. A much more simpler technique that has been used, and many other trials have been done here, is endovascular catheter based renal sympathetic denervation. So endovascular, you put a catheter inside the blood vessel. Which blood vessel? Renal artery. In the renal artery, you can ablate or you can destroy the sympathetic nerves, which reduces the renal artery vasoconstriction. This produces vasodilation in the kidneys, more blood flow to the kidneys, less stimulation of the renin aldosterone angiotensin system. And that reduces your vasoconstrictive actions of angiotensin, and that reduces the blood pressure. This too has been tried out in large number of clinical trials and found to be useful in many patients who have resistant hypertension. So, to summarize, in resistant hypertension, what we usually do is, yeah, first rule out that there is some kind of non-adherence to treatment, or look if there is something else contributing. Once you do not find that, you maximize the diuretic first, you add newer group of drugs. Think about drugs like prazosin and clonidine, which can have side effects but might be used in these patients. If nothing else works, then you can use renovascular denervation, sympathetic denervation, or you can also try to do what is called a carotid baroreceptor stimulation.